Hello, friends. So today I'll be talking on this update on management of acute pancreatitis. So I had an opportunity to do a master class on this update. So it's a useful topic for all trainees. So wish to acknowledge my colleague Dr. Bhavya who helped me develop this content. So as you see, this talk is being given on 26th August 2023, and most of the content of this talk is from the recent literature in last 1 or 2 years. So this is the most sort of a accepted standard of care with regard to evidence-based medicine, and will be useful for all the trainees when a question of this nature is asked in their exams on the update on current understanding or current accepted norms in management of acute pancreatitis. So we'll just take you through some background. So 80% of the pancreatitis are generally mild, and most of the time the treatment will be supportive, and only the rest of the pancreatitis will progress to developing SIRS and multi-organ dysfunction syndrome. So the tenets of management of acute pancreatitis in mild will only be fluids, analgesics, and nutritional goals and early nutrition. So these are some of the basic sort of tenets in approaching any management of pancreatitis. But the key thing that we need to bear in mind is, despite all the advances in our healthcare, the mortality in pancreatitis, acute severe pancreatitis, has remained unchanged over last 20 years, and it remains at around 23%. But the long-term mortality has significantly and definitely come down with severe pancreatitis. So we'll just start with the fluid. How do we approach fluid management and what is the new thing? As you see, this is a good sort of a landmark article that came in NEJM 2022 by Spanish authors. This is about fluid management in acute severe pancreatitis. So they have looked at aggressive, goal-oriented or targeted resuscitation versus moderate resuscitation, where you have a conservative approach. And in this particular study, they showed that the fluid overload was significantly more in pancreatitis patients who were treated with goal-oriented or aggressive sort of resuscitation as compared to conventional or moderate fluid resuscitation. Having done that, so obviously our whole conventional teaching is we have to resuscitate them very aggressively. And this aggressive goal-oriented resuscitation not necessarily prevented the patients to progress to moderate or severe pancreatitis, which did not help in prevention of progression of pancreatitis. And this was another study, again, as you see, this came from Thailand for 2021. Even here, they showed there was no difference with regards to aggressive or conservative or conventional fluid resuscitation. So based on this NEJM trial, so the sort of thought process or the suggestion is, try to not adopt aggressive fluid resuscitation at 20 to 30 ml per kg. Rather, have a little moderate approach with 10 ml per kg as a bolus and at 1.5 ml per kg per hour as an infusion as a reasonable approach. So be conservative in fluid resuscitation is what has been accepted at this point of time with regards to evidence. So now the whole question about, so I'm sure all the intensivists who are listening to this, we know we've had extensive sort of a literature and discussion and debate on which fluid is better, normal saline or ringer lactate. So largely we have understood for all the intensive care patients, normal saline is good enough when compared to balanced solution. Obviously, we would keep an eye on fluoride. But when it comes to TBI, traumatic brain injury, we know that saline is better than balanced solution. But in pancreatitis, it appears to be different. So this is an article which is come in 2021 by Lee et al. In gastroenterology, where they've compared ringer lactate versus normal saline in mild acute pancreatitis, a randomized control trial. So this came from the US authors. So they had 121 patients with pancreatitis randomized to normal saline and ringer lactate. They found that the SIRS, which was the primary endpoint, at the end of 24 hours, there was no significant difference between the saline group and the RL. But this was the primary endpoint. SIRS, there was no difference. But when they looked at hospital length of stay, as you see, it was significantly less in ringer lactate group as compared to saline group. It attained statistical significance. And interestingly, what they found is in secondary endpoints, necrosis, the progression of necrosis in pancreatitis was significantly less with RL as compared to normal saline. So this was also an additional benefit with Ringer Lactate. Then this was compared with all the previous studies, but there were some limitations. Here they finally randomized 121, but large group of patients were excluded from the study, and 40% of the patients were excluded due to logistic reasons, and 35.2% of the patients had liver, kidney, and cardiac dysfunction, which sort of saw the exclusion. So these were some of the limitations, which means possibly they took away the sickest of the patients in this study because they took away all the organ dysfunctions from the study, so which could be considered as a limitation. And normally, even in the mild, like I said, 80% of mild pancreatitis, 20 are severe. In that 80%, 20% of this mild pancreatitis can progress to moderate or severe pancreatitis. To substantiate to this Lee et al. Study, there are three other studies, like one from US, one from Hungary, and one from Nepal, where they've shown that the use of ringer lactate in pancreatitis reduces the ICU admission and reduces the length of stay. And this alludes to this US study where it also shows reduction in length of stay and reduction in the necrosis of the pancreas. And these studies also showed there is reduction in the inflammatory markers like CRP, and less organ failure was found in some of these observational studies with the use of finger lactate. So all in all, so this is a new dimension for all our intensivists. Like if you're dealing with pancreatitis, maybe it is reasonable that we stick to using ringer lactate based on this newest study that has come. And we do adopt the science of balanced solution as having a reasonable sort of a benefit in certain cases, and it applies possibly in this pancreatitis subgroup. So that's about the fluids. Then we'll talk a bit on nutrition. So I'm sure all intensivists listening to this would agree that early nutrition is the norm in all ICU patients, and so is the case in pancreatitis. But when do we start in pancreatitis? Because it is hugely controversial sort of a debate. Some school of thought would say that we should wait for 2-3 days until the acute phase settles down, then we should initiate, so on and so forth. So let's look into what is the newest evidence that is evolved in nutrition. So the rationale for saying that we should not allow these patients to be in NPO or fasting is because when they're kept nil per mouth or when they're not being fed, so it leads to gut failure, and there is increased translocation of gut translocation of microbes, which is not good in pancreatitis. So this was a new study which it came in 2021 in Annals of Surgery, again by Spanish group called PADI trial. So they took 131 patients with pancreatitis. So IORF is immediate onset of resumption of feeds, immediate oral resumption of feeds, and CORF is conventional oral resumption of feeds. So as you see, the hospital length of stay was significantly less in the group where there was immediate oral resumption of it, where early feeding happened, and progression to severe pancreatitis also was lower in this group, immediate oral resumption of feeds, and progression to multi-organ failure, complication, and ICU admission also was significantly less in early feeding group, where there was immediate oral resumption of feeds as compared to conventional oral resumption of feeds. Then there was a good Indian trial also, 110 patients, where they looked at early means hunger based, where patients start asking for oral liquids or diet, they started feeding. And the late is where obviously you would wait until the inflammation settles, until the acute phase settles, and then start feeding. Here also they found the hospital length of stay was much lesser as compared to the late feeding. So basically the science remains as we sort of reconcile to in ICU that every ICU patients have to be fed early. So is the case in pancreatitis, and this is substantiated by these two studies, PADI trial and this Indian study, which tell us that early nutrition reduces the length of stay and reduces the progression of the pancreatitis, which is possibly more relevant to us. And to substantiate this, there are two meta-analyses also, which shows one is from US and one from China. Both show that early feeding shortens the length of stay in pancreatitis. So conclusions, what we can make based on these two meta-analyses and these two RCTs is when someone is not being able to feed orally within 3 days in ICU, nasogastric feed has to be initiated, and parenteral nutrition should only be considered for persistent feed tolerance. What it means is you within 3 days try to see if patient can start taking oral resumption of feeds as shown in Spanish trial. And if they're not able to start NG feed, even if they're not able to feed in nasogastrically, one has to move on to try and see if they can put a post pyloric tube and try to feed them. Even if that is not feasible for whatever reasons, even that is not being tolerated, then only one should think of parenteral. So early feeding within 3 days is the way to go in pancreatitis. And within 3 days, you're not able to give orally, start nasogastric. If nasogastric feed tolerance is not happening, move to post pyloric tube. Only after that you should contemplate. So feeding is here to stay and early feeding is the way to go. So that's about nutrition. So let's look into pain management. So pain management in pancreatitis, there is emphasis on multimodal sort of a pain management. What it means is we have to give paracetamol, which I'm sure every intensivist would be giving for pancreatitis. Along with paracetamol, opioids is something we need to give, but there is a flip side for opioids because pancreatitis patients have ileus and giving more opioids can worsen ileus. So we have to balance with paracetamol and opioids. But two important things that has been emphasized is use of rectal NSAIDs. So this has come up, which I'm sure was new thing to me because we were not aggressive with the use of rectal NSAIDs. So the rectal NSAIDs is something that has studies have shown good benefits. So that is something possibly is a new thing for all my intensive care friends. You can adopt this usage of rectal NSAIDs. Obviously, we would be worried about AKI in ICU. So someone with severe pancreatitis with AKI, we have to be very cautious when we are considering NSAIDs. The fourth important thing which we use it normally in our ICU and which we have been using for last 10 years in acute severe pancreatitis, when they come with severe pancreatitis, is epidural analgesia. For this, there is a good study. This was a retrospective study done in 352 patients where use of epidural analgesia showed protection in pancreatitis against development of ARDS, AKI, and mortality. So there is a good study also to substantiate. Consider epidural in patients with severe pancreatitis as a multimodal approach to analgesia. And there are two meta-analyses, one from China and one from UK, one with 6 RCTs and the second one with 12 RCTs, where they've shown NSAIDs and opioids had equal effectiveness with regards to analgesic effect. So our approach should be multimodal. Obviously, paracetamol is safe to use opioids, and NSAIDs is a new kid on the block, which there is a push to use rectal NSAIDs in pancreatitis because oral absorption can be an issue. And and epidural definitely to be considered in patients with severe pancreatitis and there is a study to show that it prevents progression of other organ dysfunction and even mortality to that effect. So that's about pain management. So prophylactic antibiotics, I'm sure everyone listening to pancreatitis would be upfront in starting antibiotics. So there is a de-emphasis and underwhelming of your enthusiasm to start antibiotics. There's good enough evidence to say that we should not unnecessarily start antibiotics. There is no role for prophylactic antibiotics. And this was a meta-analysis from China with 7 studies. And as you see, this came in 2022 where they've shown carbapenem prophylaxis in pancreatitis showed a reduction of occurrence of UTI, bacteremia, and pneumonia, but did not have any effect on progression of pancreatitis to necrosis, did not have any effect on mortality, and did not have any effect on clinical outcomes. So there's no role for unnecessarily starting prophylactic antibiotics for pancreatitis. And even in our practice, we don't start any pancreatitis patients on unnecessary antibiotics. So we finished fluids, we finished analgesia, we finished nutrition, we finished antibiotics. Now, what about role of pre, pro, and postbiotics? So there is some emerging evidence on the role of prebiotics, probiotics, and postbiotics. So there are two randomized control trial, one from India, as you see it is in 2022, and this was from China in 2021, where they've used certain probiotics like synbiotics or Bifilac. They've used the probiotics with Bacillus subtilis and Enterococcus faecium. And the use of these probiotics and prebiotics has shown some benefit in reducing the length of stay, but there is no effect on overall clinical outcomes. So, as you see in pancreatitis, most of these newer sort of suggestions or signals suggest has effect on reducing the length of stay. So this was one study where they used postbiotics in 49 patients where they used soluble dietary fiber, which is a postbiotic like polydextrin. So the usage of this polydextrine in this trial showed feed intolerance significantly could be brought down from 72.73% to 29 point. So feed intolerance came down. So the tolerance of feeds was improved with the use of postbiotics. So there are studies done on use of postbiotics like butyrate, which is a short chain fatty acid in animal models. Right now, there is an ongoing trial on postbiotics tributylin, which is a postbiotic being tested in pancreatitis. So this is about, so there is some emerging evidence with the role of probiotics in pancreatitis, which currently we are not using as a standard of care, but it appears there may be no harm and it may have some beneficial effect on secondary outcomes is what we can deduce from the current understanding. So then we'll move on to once patients has come with a biliary pancreatitis. So then these patients would undergo ERCP for addressing the cholangitis in these patients. And when these patients go for ERCP, they can develop ERCP pancreatitis in biliary pancreatitis, where they undergo ERCP for relieving or for addressing the cholangitis, and then there can be worsening of pancreatitis in post ERCP. For this, the suggestion is to use 100 mg diclofenac. Rectal diclofenac sodium has shown to be very effective in mitigating this post-ERCP pancreatitis. And in post-ERCP, so post-ERCP basically you put in an endoscopy to relieve the biliary drainage or to facilitate biliary drainage. In the attempt to do this, there can be pancreatitis. So the suggestion with the current literature is to place a pancreatic duct stent. As you see, there is a stent placed in the pancreatic duct, which is shown to prevent post-ERCP pancreatitis. And there are studies done in post-ERCP pancreatitis, again with ringer lactate. So this is a Dutch study, whether aggressive versus standard. So it means when someone has undergone ERCP, if they develop pancreatitis, should one be aggressive with fluid resuscitation? So aggressive fluid resuscitation has not shown a major sort of an impact on reducing post-ERCP pancreatitis. PEP is post-ERCP pancreatitis. With aggressive fluid resuscitation, it was 8% as compared to the standard, it was 9%, which means it did not make any difference. Even in post-ERCP pancreatitis, being aggressive with fluid resuscitation not necessarily reduce the post-ERCP pancreatitis. And they have done a study at rectal diclofenac versus placing the pancreatic duct stent, PD stent, versus combination, and they found that rectal diclofenac, this was a Japanese study, was good enough compared to placing pancreatic duct stent or combination. So there is an emphasis on using rectal diclofenac as a means to prevent post-ERCP pancreatitis as a good analgesic. And even previously, we saw that it can be used as a good tool or a modality to prevent even to some extent progression of pancreatitis. So all in all, there is a renewed emphasis on using rectal diclofenac, which obviously we are not currently using. So the listeners, I don't know if any of you guys may be using, but this is something which is new, which we could adopt in our ICU. Obviously, paying attention to the kidney functions in our ICU patients. So we'll move now to management of. So that was all about pancreatitis in the initial phase. After initial phase, obviously all pancreatitis develop complications, and when they develop, how about the antibiotic treatment? Again, so there is a sort of a reference as to two-thirds of the pancreatitis patients end up on antibiotics, although there won't be any proven cultures to substantiate usage of antibiotics, or there is no proven radiological substantiation for usage of antibiotics. The reason is because for any of the clinician, it is hard to delineate whether it is a first response or the infection, because both of these cause rise in the total count and cause high fever and high inflammatory markers. So it is hard to delineate whether it's a surge that's happening or whether it is infection. So this leads to significant proportion of pancreatitis patients to go on antibiotics. So this was a study from UK in 260 patients where they used what's called ProCap trial. So it is useful for all the it is useful for all our trainees, ProCap study. So 260 patients where they used procalcitonin guided antibiotic use, and they saw the antibiotic usage was significantly less where they used procalcitonin as compared to the usual care. Here they used procalcitonin at day 0, day 4, and day 7, and they started antibiotic when procalcitonin was more than 1 nanogram per ml to start antibiotics. And they stopped antibiotics if procalcitonin was less than 1 nanogram per ml. So this was a good study, useful for all our trainees, and they saw that the infections and the adverse events was similar between the procalcitonin guided antibiotic usage and the usual care. So there is an emphasis on the use of procalcitonin to substantiate usage of antibiotics in pancreatitis. And this is a good reference study, which is called a ProCap trial, which came in hepatology in 2022. This is the latest study where they've done serial procalcitonin to determine whether anyone should be started on antibiotics. And they've taken reference of 1 nanogram per ml of procal. If it is more than that, as a substantiation to start antibiotics. So this is a good study for all intensives. If you have to justify usage of antibiotics in pancreatitis, at least do procalcitonin, see the rising trends. If it is more than one, I think you are reasonably substantiated. Otherwise, one could wait because in those situations, it may be due to the thirst. So now we'll move to the management of severe local complications because as most of you would know, pancreatitis would develop a lot of fluid collections, so on and so forth. So there are a lot of interventions that are done to remove this necrosis. So some of the commonly used terminologies are this is video assisted retroperitoneal drainage, which is like a laparoscopic drainage of necrosis. But now there is a renewed emphasis on being less invasive with using transgastric drainage, and necrosectomy is a surgical approach. So there are studies to substantiate that maybe it's good to adopt less invasive ways to drain the necrosis, and that is transgastric drainage. So basically, you put an endoscope into the stomach, and transgastrically you reach the pancreatic. So this dark sort of a area is the necrotic aspect of the pancreas. So transgastrically, they approach the necrotic area and drain the necrosis that is present in the pancreas. So this is what is being now looked at as an option. So the success rate for the transgastric drainage of necrosis is 87%, and there is a good study for this. So again, this is a Dutch study which came in 2022, where they have compared transgastric endoscopic removal of necrotic fluid and they compared to the surgical step-up approach. And they say surgical step-up, you know, there will be a staged surgery to remove necrosectomy, and they found the outcomes were similar between the transgastric endoscopic removal of necrosis versus step-up surgery. And with transgastric endoscopic way, there was less fistulas as well that occurred, and that was the benefit. And the key aspect that is emphasized with dealing with the local complications is any drainage attempt of the necrosis should happen only when there is a clear walling of the necrosis. There should have been a clear wall formed around the necrosis. Only after that, drainage attempt has to be done. So to that effect, there was a good, again, Dutch trial called the Pointer trial. So this Pointer trial was a 5-year follow-up of the registry data, where they looked at patients who had early drainage of this necrosis. Early drainage happened at the mean of 24 days, and the late drainage happened with the mean duration of 34 days. And they looked at comprehensive complication index, and they found there was no difference between early drain and late drain. Having said that, but in the late drain, 39% of the patient missed or did not have to undergo intervention, which is an advantage. So the Pointer trial says it's better to wait for much longer time until a good walling of necrosis happens and interventions to be considered much later for the necrosis, because the late drain route had less interventions, 2.6 sort of a days and 4.4 was in early drain. So the intervention days was much lesser with the late drainage. So there was an advantage of considering late drainage with regards to this local complication was what was shown in the Pointer trial. So which means the late drain patients had less interventions as compared to the early drain patient group. So that, and there was another study called Acute Must study, which considers the transgastric drainage along with the lumen opposing metal stents, which can be kept in place as an additional advantage. So what we can decipher from these trials is it is better to adopt transgastric endoscopic means to remove the necrosis, and maybe one could wait for a little longer time, up to 34 days, for these interventions and manage these patients with antibiotics and so on and so forth, because this could avoid the number of interventions, and it may even prevent some of the patients to undergo such intervention. So there is emphasis on multidisciplinary team approach when we are dealing with the late complications of pancreatitis. When we say multidisciplinary team, it will be with intensivists, with the surgical gastroenterologists, and with interventional radiologists, with radiologists, and so on and so forth. And there is mention about neostigmine to be considered to reduce intra-abdominal pressure and to reduce the ileus and to promote gut motility. And this is something we do use it in pancreatitis, so one could embrace this lot more to circumvent the intra-abdominal pressure and abdominal compartment syndrome. Then there's a mention about the duration of cholecystectomy. If it is a biliary pancreatitis, there is a debate whether one should consider doing early cholecystectomy versus late cholecystectomy. Early is less than 8 weeks and late is 3 months. It is shown that early cholecystectomy is better off in reducing the biliary recurrence or reducing the risk of recurrent cholangitis is what has been suggested. So just a last slide on immunomodulation, whether there is a role of immunomodulation. So all the extracorporeal sort of therapies that we use in severe pancreatitis. So this was a meta-analysis for high volume hemofiltration, meta-analysis of 17 studies, again came from China, which showed that high volume hemofiltration has shown to reduce short-term mortality, but no effect on long-term mortality. I'm sure most intensivists would be knowing about cytosorb, which is a cytokine removal extracorporeal hemoperfusion. So this was a randomized control trial called the Pacific study, which again came in 2022 from German group, where they compared 16 patients with severe pancreatitis who underwent cytosorb or cytokine removal with the extracorporeal circulation and compared with the control group, 32 patients, and they found that the patients who got cytosorb had good hemodynamic stabilization or improvement. But overall, they looked at all the interleukin levels, they looked at interleukin 6, all that came down. Hemodynamic improved, but overall outcome, it did not make a difference between the standard group. And they have looked at thymosin alpha. This was a study again which came in 2022. There was no benefit with the usage of thymosin alpha 1. And there is a mention on the immune paralysis that sets in acute severe pancreatitis in the later phase, and that leads to all the late infections, which means after pancreatitis has settled, these patients are at a much higher risk of developing recurrent infections later due to immune paralysis. There's an interesting concept that has been come out with the multi-omics, where they do the genotyping and they've identified 4 subtypes of molecular endotypes in pancreatitis, and they found that the subtype 1 are the ones who develop persistent organ failure in pancreatitis. So the way forward is trying to look at the phenotype and the genotype of these patients, and if they fall in the subtype 1, and these are the patients who possibly will have a guarded prognosis with persistent organ failure. So this is something which is futuristic and may help us to prognosticate pancreatitis in much better way. So the conclusion, just to summarize the whole understanding of the current standard of care in pancreatitis. So don't over resuscitate fluid. So be modest with your approach to resuscitation, especially in acute severe, because we have clearly understood that over resuscitation also is bad. So stick to 10 ml per kg as a bolus and maybe 1.5 ml per kg per hour as maintenance if we are not feeding in the acute phase. And this is something new to all of us. So adopt ringer lactate as opposed to normal saline in pancreatitis because of good studies, the Lee et al. Study, and there were 3 observational studies which show that use of ringer lactate reduces the risk of ICU admission and reduces hospital length of stay in severe pancreatitis, and is shown to reduce your inflammatory markers and less organ failure. Nutrition, I think every intensivist would agree. So we have to treat every pancreatitis early on. Within 3 days should be your target to start feeding. If you're not able to feed orally within 3 days, start nasogastric, move on to postpyloric if they're not tolerating nasogastrically, but parenteral nutrition to be only reserved if there is a persistent feed intolerance. And all this has shown to reduce hospital length of stay. With regards to analgesia, the new thing for all of us is try to adopt rectal usage of NSAIDs, obviously keeping an eye on your AKI, and do embrace the principle of epidural in severe pancreatitis. And there is one retrospective study you saw which showed reduction in mortality and reduction in the length of stay and reduction in the progression to AKI and ARDS. And antibiotics, please don't use antibiotic prophylaxis. There is no role. And even if you are considering starting antibiotics, if you're not able to delineate between SARS and the infection, use procalcitonin. You have that ProCap trial, which has come in 2022 in pancreatitis. So if it's more than 1 nanogram, you use antibiotics as to substantiate your usage of antibiotics. And with regards to late complications, obviously the experts would be your gastroenterologist. So try to adopt non-surgical means like transgastric approach to address this necrosis has shown to benefit. And the pointer trial suggests that maybe late intervention is better because this could avoid unnecessary interventions, lessens the need for interventions, and around close to 40% of them, these interventions could be avoided by waiting for up to 30 to 35 days before we jump and do multiple interventions in them. So this is the latest with regards to the principles that one could adopt in the management of pancreatitis. So I request all the listeners to consider submitting your valuable work to Journal of Acute Care. So we have interesting educative domains in this. So we have video CME, then we have a postgraduate sort of a section in this. So I request each one of you to submit your valuable work. So visit my website www.drpradeeprangappa.com to rehear to this lecture. So thank you one and all.